My name is Ronald Baird. I am the interim dean of the Brown University School of Public Health, serving until Dean Ashish's job comes back from a temporary, short-term assignment to the White House. We always want to emphasize that. It is my pleasure to welcome you to one of the highlights of the commencement weekend. Before we get started, I would like to thank members of our school community, starting with the staff who have capped off a complex, challenging year with this wonderful commencement in person for the first time since 2019. The faculty continue to lead us and to grow rapidly to meet the demands of this moment, when the work of our school has never been more important. And students, you are the soul of our school. Your curiosity, resourcefulness, and drive to improve the health of all is an inspiration to us all. Parents, families, last but not least, who have sustained and supported our students through what has been a very challenging course of study. This afternoon, we are fortunate to have some of the world's leading public health thinkers and practitioners for a frank conversation about what we have learned in the course of this pandemic. The pandemic has exposed immense disparities in health systems and access to health care and health outcomes, both here in the United States and around the world. The COVID-19 pandemic has challenged us working in public health to envision new approaches and new interventions to build a healthier future, particularly for those who've been overlooked in our pandemic response, as they have been in broader public health challenges and economic disparities and discrimination, rooted in economic disparities and discrimination. We could not have a better group of leaders here today to talk about these challenges. Stefanie Friedhoff is a professor of practice and senior director of strategy and innovation at the Brown University School of Public Health. Stefanie studies relationships between information needs, misinformation, health outcomes, including the difficulties faced in maintaining demand for vaccines in the United States. Her leadership and innovative thinking is providing all of us new and important sources of information on this new important information and data on this pandemic, and a deeper understanding of how to communicate effectively. Zeynep Tüfekçi is a New York Times columnist and a visiting professor at Columbia Journalism School, where she will become the inaugural director of the Craig Newmark Center for Journalism Ethics and Security in July. From the earliest days of the pandemic, Zeynep has written remarkable insight and foresight about the analytic failures that have continued to undermine our ability to respond effectively. John Nkengasong is joining us virtually. John has served for the past 5 years as director of the Africa Centers for Disease Control, leading the organization's response to multiple outbreaks of Ebola and other emergencies. John has played a key role in Africa's response to the COVID pandemic, helping to coordinate responses around the continent and advocating tirelessly for vaccines, testing supplies, and therapeutics. After his recent confirmation by the United States Senate, John will take office as the coordinator of U.S. global response to HIV and AIDS. With those introductions, I will hand the mic over to Stefanie, who will help guide us to what certainly will be a fascinating conversation. Thank you.
Thank you so much, Ron, for the fantastic and kind introduction to all of us here. We were just talking about how we're all having a little bit of phobia, so people move away from you. It's not personal, because we're all in the room together again for the first time in that right now. It's almost a little bad. Thank you for being here today to talk with us about long-standing health inequities in global health and public health. We think of global as global. The United States is part of the world. There are great disparities within this country, as we see in other countries too. So it's a general framing as we get started. And I want to start out by acknowledging that we're gathering here today on the ancestral homeland of Americans and Indian tribe. The university last year began a process of acknowledging the complex and painful history of the land on which Brown sits, and now it will be a long process of reckoning. It's also interesting, it follows 15 years after the university began investigating the university's role in slavery and the slave trade. There was just a talk an hour ago here on campus that presented the second report that comes out of this work. I urge you all to look at it and read through it. It's important. And these are really the beginnings of the type of institutional change that we need and want to see as we try to make a difference and try to make change on health equity. We've talked enough about people's individual choices, so we need to talk about the role of institutions and all of us on this topic. We often hire people of color to then work on these topics for diversity. Community organizers around the country, on the other hand, always say we are the leaders that we've been waiting for. Maybe President Obama said it, he didn't coin it, doesn't matter, right? He put it into everybody's ear, at least here in the US, to make sure that we all know that we have a role to play in this. So I'm hoping we can use this conversation today to learn, to listen, to find inspiration, and then to really visible and act. It's a long game, and every step matters, no matter how big or small. I'm excited, as everybody else, of course, to be here with these two fantastic speakers. John Nkengasong, I met a number of years ago at the Harvard Global Health Institute, John, when you gave a fiery speech. And you stood out, for decades now, starting out as a virologist, really helping us see new pathways to how we respond to infectious diseases, not just on the continent of Africa, but around the world. And Zeynep, I think, also needs no introduction for everybody who reads in this country. Has risen to fame as a leading thinker in this pandemic. And you want to read up on Zeynep's background, really. Decades ago, I studied science, technology, and society at MIT, and it is that really important connection in between fields that Zeynep lives, and I think that is key to how we interpret these moments that we're in. So, again, like you, super excited to be here with these two. And Zeynep, we're going to start with you. The pandemic has made, as I think we've all observed, crystal clear how these long-standing inequities play out in the crisis. Black and brown Americans confront an overwhelming burden in this pandemic, starting with a higher share of low-paid jobs, essential jobs. You cannot work from home. How many times have you said work from home? Well, for people in this country, that's actually not an option. They have a higher share of congregate housing, and that puts people of color at a higher risk of getting infected. Once you do get infected, if you're Black, Hispanic, or Native, and get COVID, you get hospitalized and die at twice the rate of white Americans. That is unacceptable. But it is a reality every day. And that is due to the underlying conditions that stem from, again, these inequities and racism, as we all know. When George Floyd was killed by police in summer 2020, and people went to the streets saying enough is enough, there was a collective scream about the ongoing mistreatment. And while white journalists were quibbling about safety and rallies, Black people were saying that COVID can just get in line with all the other threats to health and economic stability that Black people in this country already face. It was a major moment that crystallized that while we all live in the same country, we don't live in the same world. We face very different realities. So Zeynep, you actually have studied movements. You've studied liberation movements in different countries, as well as responses to this pandemic. How do you interpret that watershed moment early on in summer 2020? And where do you think we are now? Are we seeing signs of change when it comes to that? Easy question to start.
Yeah. That is a very difficult question. So I did study, I've studied social movements for a long time. And one of the ways that I'm pausing because it's such a complicated answer that I'm going to try to say in the sort of more compact way that I can is that one of the things that it's misunderstood is that movements don't just succeed or fail in a binary way, but you can look at certain aspects of what they do, because movements aren't a singular thing, and try to understand how that happens. I think on the policy front, globally, what we have seen is this inability for even large social movements to make significant progress on certain issues that are relatively popular, have a lot of support behind them, and have people join movements, and yet it doesn't turn into the kind of sort of lasting policy-based change that people have been hoping for. And I think that's partly how we're living through a legitimacy crisis, in that people try to vote, and then people try to protest, and people try to do various things. And if you look, sort of turn back and look, it doesn't necessarily lead to the kind of change things that people look for. And that challenges some of the notion, because when I used to teach introduction to sort of social movements, I would usually have to unteach the Hollywood version of the story for at least a civil rights movement, which a lot of people learn in high school. And their story was something like, there was a little lady who got tired one day on a bus. She sat down, she was arrested, and then some stuff happened, and then there was a great speech by Dr. King. He had a dream, and then some legislation was passed and progress. So that's kind of like what they come telling me. And then we start by, well, she wasn't the first person to be arrested for sitting at the back of the bus. She was on a long line of protesters, but the movement strategically picked her with like days of consultation, because she was putting her life on the line, and they picked her because she might have been tired, she might have been short, but she was tough as nails. She was a lifelong activist, and she said, all right, I'm going to do this. I'm going to put my life on the line, and we can go forth with this. Some of the reasons she was picked would seem difficult to today's movements, because they wanted somebody who would, it could be the face of the movement, so they did not pick some people who were younger or did not seem to fit their politics as well. And then that speech, Dr. King had given that speech many, many times before in various versions. He didn't just come up with uniquely inspiring words he had uttered only on that day. In fact, it was a movement that took 10 years to get to that mall, and it was that movement with some allies and a political reality and all those things. So I sort of have to, and they go, oh, because the Hollywood version also always ends in success, and reality does not always end in you are just, therefore you will be rewarded. I think that's sort of a big misunderstanding. The sort of arc of history is a very nice way of phrasing it, but it doesn't just work. So that's, so in that kind of way of thinking, I think we really face headwinds, and that's why we face a legitimacy crisis where people around the world, not just in the United States, feel like we're not making progress in the ways that, as I said, even on things that are have enormous popular support and protest. On the other hand, protest isn't just like, doesn't just give you, or social movements don't just give you the binary result or not. It's where people find one another. It's where people start thinking about what kind of world they want to be. It's where communities are formed, and there are many, many other things that come from protest. So in that kind of way, I think there's a lot more engagement with the understanding that, yeah, we're kind of the ones we're waiting for. Like, it's not going to happen, and if anything, we have, dare I say, a bipartisan failure of, it's not equal, perhaps. In fact, it's not equal, but there is a sort of a system-wide failure of different kinds across the political spectrum in terms of realizing what needs to happen. So that's kind of, the reason I say it is that people always want to pin it down to a yes and no. Was it good or not? And I want to say, yes and no. It's complicated. You can't really sort of look at it in that particular way. So where we're going from here on is the real question, I think, for all of us. And I think what the pandemic has revealed and in fact worsened the institutional, I think, failures. Like just our institutions have greatly hollowed out and failed and have not kept up with many things across the board that we suspected was the case, but this was like a stress test. And a lot of institutions that I didn't have a lot of high expectations for did not do well, but a lot of institutions that I did were also shown to be not up to the task, and there's a lot of historical reasons why that's the case. So once this kind of winds down, what I hope is a reckoning, a real reckoning, not to try to find who was guilty and let's sort of scapegoat them, but if you don't have that kind of reckoning after a stress test of this magnitude, you will get another reality test and it'll just be even worse. I realize like no blame reckoning sounds like a pipe dream, but at least one can dream so that we have something to aspire to and fail from an ideal rather than not even trying and just kind of going back to, okay, that's done, now let's go hit another wall in a frustrating way.
Thank you so much, Zeynep. Dr. Nkengasong, John, you've kind of led a different kind of movement in Africa, the movement of excellence, a movement that speaks through action. We all know that the deep disparities in the US are connected to the disparities in the world. They stem from a long history of colonialism and other atrocities. The COVID pandemic, however, has also been a reminder of how differently this has played out in different countries. In Africa, the African continent has really stood out as an example of how much the world of global health has changed. People, of course, were surprised by how the pandemic didn't, create the type of havoc that was predicted for countries that have been historically seen as on the receiving end of global health interventions. Instead, the continent has provided many examples of leadership. So tell us a little bit more about both how you've been able to lead such a fantastic response within Africa and this new public health order that you see emerging.
Thank you. Let me, first of all, join others in congratulating the Brown University for this year's event. We have to celebrate every achievement. Can you hear me?
Yeah. A little bit, you could be louder.
Can you hear me now?
Yeah, they'll pick it up from there.
Yeah.
Oh, great. So I was just saying that we have to celebrate every event that we come face to face, and it is a reminder that this pandemic too shall come to pass. Like the 1918 pandemic came to pass and went into the records of the history of pandemics. However, I think we should also, as the previous speaker said, be mindful of the fact that we really have to be courageous to admit that there have been failures, and the only failure in this pandemic is to admit that there were failures that we could have avoided, and that the institutions and the health security architecture that we had in place really requires that we take a very serious look at it. I would try to expand on two themes that the promise of multilateralism needs to be reviewed. We all have been governed since 1947 by the multilateral systems that were set up and were supposed to be working for everybody. I would argue that that wasn't the case for the continent of Africa. I will also expand on the fact that because of that, it gave rise to what we call the power of regionalism, where the region organized itself and so perfectly and with very strong political backing to solve a problem that was literally abandoned to that continent. So let me maybe start off by saying that there are three key things that I always like to start with, that this pandemic has taught us about the connectivity of our humanity, the vulnerability of our humanity, and the inequalities that exist across, within countries, across nations, between regions, and even in communities. I think that those three things, in my view, will forever characterize this pandemic. And that we also now know that a disease outbreak, we used to say that, but we have seen it, we've lived it, a disease outbreak anywhere in the world is a threat everywhere in the world and has serious economic consequences, serious humanitarian consequences, and serious national security consequences. I underline and bold that because we have seen that across the continent of Africa and elsewhere. We've also seen how the outbreaks or pandemics results to extreme tension and the imbalance in geopolitics that we have to factor in and make sure that courses on such are taught in our public health programs, and not just the standard public health practice, but that in pandemics, there are other factors that come into play, and I'll come back to that. So let me now expand on the multilateralism. When the pandemic hit all of us, we recognize how, as a continent, it was so difficult for the continent of Africa to have access to basic diagnostics. Even when countries had the money to buy diagnostics, there was nowhere to turn to buy diagnostics. So the continent, when today we say that the continent doesn't test a lot, I mean, that there's a history to that, because there was scramble for diagnostics. And even I remember head of states calling me to say, hey, look, John, you are the head of CDC, we have money, we can buy as many diagnostics, tell us where to go get diagnostics. And I'll probably just tell them that, well, Mr. President, unfortunately, we don't know where to send you to. I think that is very important. Now, when we thought that that inequality or inequity was going to be restricted to diagnostics, we actually wrote a commentary in Nature where we said, as vaccines become available, and that was in 2020, we should do everything possible to make sure that vaccines are accessible in a timely fashion to everybody that needed to be vaccinated. We made that plea clear. We took that an argument to the head of states of the continent, and they endorsed that. Now, and this is where multilateralism comes in. A COVAX mechanism was set up, which in my view had the best principles. It was designed to provide timely access to all countries. I've always characterized that as a symbol of great solidarity and a symbol of great cooperation. But the translation of that concept, that multilateral concept to reality remains work in progress. To the extent that as a continent, Africa is only 17% fully vaccinated. And again, remember what I said, that our humanity is terribly interconnected. So if the continent of Africa is only 17% vaccinated, I will also then submit that we are not collectively, and I use the we as a collective we, out of the woods yet, because variants are emerging, and we just don't know what is ahead of us as the global community. So that is an example of where we have to go back and look at our multilateral systems and say, how do we hit the reset button and make sure that it works for everybody and not just some parts of the world, because a disease threat, as I argued before, is a threat everywhere in the world as long as it remains a threat anywhere in the world. Now, let me then reflect on the power of regionalism. Because of that scarcity, the continent of Africa got organized. And they said, look, we have to take our problems, lift it up, see it in the eyes and solve it. And they set up 12 initiatives, including an initiative to acquire vaccines for the continent that made it possible for 400 million doses of vaccines to be acquired. They set up the African Medicine Supply Platform, commonly called AMSP.Africa. You can Google that, you see that information. I'll repeat, AMSP.Africa. A website will pop up like Amazon.com, and you can actually go in there. if you're a member state, to buy health security commodities. So because of that push and that what I call the lapses or the failure of the promissory note of multilateralism, that regionalism emerged. I want to end by just saying that we should always, in the spirit of redefining our global health security architecture, make sure that we look at it in 3 levels, that as we all strive to strengthen central mechanisms, i.e. the WHOs of the world, we should look at regional bodies that have emerged during this pandemic for the common interest of all of us, like the Africa CDCs of the world, the CARIC, and other parts of other regional bodies. We should also look at national systems and make sure that all 3 levels of systems are strengthened so that the next time we're faced with a pandemic, we are not scrambling. We actually scrambled during this pandemic. And again, just to emphasize the point that was raised earlier, I don't think I've seen bold conversations that speaks to the need that we need to address this global health security architecture at multiple levels. Thank you.
Thank you so much, John. If I can just jump in there for a second. I'm so glad you brought up COVAX. It's a bit of a half glass empty, half glass full situation, depending on how one wants to look at it, right? Nations came together and tried to make a difference. However, the execution, as you say, isn't where we want it to be. Could you talk a little bit more about why? What are some of the reasons of why COVAX hasn't been able to vaccinate more people on the African continent?
So it all has to do with the timeliness of access. So if you all recall that in March of last year, the first doses of vaccines that were procured through COVAX started arriving the continent. And then suddenly there was a stoppage of that because the Delta variant emerged in India, and COVAX had allocated more than $1.2 billion or so to India at the Serum Institute to produce vaccines. And I remember being at several airports on the continent to receive vaccines. And so the first doses were administered, and then, of course, subsequently, there was no telling when the next doses would come. And that created a huge distrust factor, which till today we are still struggling to overcome on the continent, because the question that people keep asking me is, what happened? And it became extremely difficult to respond to that. So that is one. Second is that we all know that COVAX struggled to sign contracts with vaccine producers because countries that had the resources had acquired most doses of vaccines. So COVAX became this body that was a promissory note, had the money but didn't have access to vaccines. So you could not deliver on that promissory note. So I think those 2 factors are very critical. Now, the narrative that you get out there is that, oh, because of vaccine hesitancy, the continent is not vaccinating enough. That is not true. If you have published studies in Nature that clearly shows that 80% or more of the continent wants to be vaccinated. Okay, we've conducted our own studies at the Africa CDC to show that more than 80% of the continent wants to be vaccinated. In some countries like Ethiopia, 95% of them. Yes, there are some countries that have a low rate of acceptance in theory. But if you match those studies, including a study from the World Bank, and what is actually going on, you see a gap. There's a big gap between what people want to do and are willing to do and what is actually happening on the ground. So I think we should learn a lesson that the next pandemic, building trust with the community, what I call the trust capital, is so important with the community. Once you bridge that, it becomes very, very difficult to re-establish it in a timely fashion.
Indeed. Thank you so much for that. We could go a lot deeper there. We'll shift over a little bit. As you've also made amply clear, John, is that the narratives matter, right? We were speaking with a colleague in South Africa recently who said, you can bring more vaccines, just keep the misinformation. The import of misinformation into the continent and the world, obviously, that comes out of the US is a big issue. So the stories we tell ourselves kind of have been misleading for a long time. And there's a great connection to our equity topic today, because we've told ourselves stories about race, about who deserves to be healthy and who deserves to have a decent job. That, of course, we all know were more about power than truth. And they have destroyed so much trust. So again, Zeynep, you're a scholar of all these things, of the stories, how we make sense of things and the stories we tell ourselves. What are some thoughts and ideas you have about how we can begin to address these false racist ideas that have been embedded in our narratives for so long?
You ask very easy questions, don't you? So I do want to say one thing about the global aspect of it. So as you know, like I study these very, it's not even interdisciplinary, these sort of multidisciplinary intersections of, societies changing and all of that. And before I used to do a lot more on the technology side, and that wasn't very popular for a while. People thought, technology, what is it going to do? It's irrelevant. Why is it a social science topic? Like, are you studying user interfaces? So I wouldn't, like, it took a while to get like the social sciences to take this seriously. So I would be assigned the introduction to sociology classes to teach, as well as statistics and methods. That's what they do if your own topic is not seen as very good for the discipline. So you get the intro classes and you get stats and methods, because I was, I'm a stats person. So I was like, fine, great. I like those topics. And when I used to teach intro to sociology, so intro to sociology is a very regimented class, like it's all over the country. Therefore, it's a great textbook market. Like the textbooks sell a lot. If you write one, that's like, you're going to make a lot of money. And they're all similar, like chapter 1, the sociological imagination, chapter 2, culture, and then chapter 3. So like very sort of, you can swap them out almost. So it would be race, chapter 3, gender, chapter 4, usually, then class, and then globalization. So in my experience, the students would be super engaged with questions of race, super engaged with questions of gender. Culture, they would be super engaged, and just hated the fact that I would use Disney as an example of problem stuff, because they're like, you can criticize anything but my childhood, but so that was a challenge. And then we would get the class and they would kind of start getting less interested, because in most universities there's such class uniformity that they don't really have experience with, like they all kind of come from a particular strata, and there's very few around them, like first generation poor background students. They exist, but they're kind of invisible to them. So there'd be this clear drop in interest in the topic. And then we get to globalization and they would completely start like sleeping in the lecture hall. This is like a decade ago. That's how I started teaching about pandemics. I was trying to I was trying to explain a bunch of stuff to them. And I thought, like, they don't care. I would talk about immigration. I would talk about this. They kind of were just not engaging. And I started teaching about, what we were hearing, in that we're connected. We're very connected. Pandemics have shaped human history forever. And when you have travel, when you have trade, when you have interconnectedness, like they are going to happen again. They've happened forever. And that's why you have to care about disease surveillance in a country that you may have never thought about. And you also have to think about the interconnections and WHO and all of those things. And I would do these sort of maps of sort of airports and airlines and all of these things. And I would just try to say, your idea that you can be an island and be isolated from letting this global infrastructure not work the way it should. I would try to argue, and they would get some. So that was like how I got into writing, like thinking about these things to try to get through. And the only thing I wrote before this one about sort of health infrastructure stuff was when we had the Ebola freakout in the United States, when Craig Spencer got diagnosed, and all of a sudden everybody was like just sort of absolutely freaking out. Meanwhile, what we were seeing was in the original phase of the outbreak, they didn't have enough buckets, they didn't have gloves. There was this incredible resource shortage, and we were all instead worried about this very, very remote possibility of a few more infections in the United States, rather than thinking, wait, like, how did we get to this point? And then Craig's currently a friend, so with all due respect, and I wanted him, of course, to not die, but like the way we were all focused on, and I was kind of like, this is terrible. We're not like looking at where we should be looking. The reason I kind of bring this up is that there is this idea that wealth and privilege will isolate people forever sometimes. On the other hand, unfortunately, it has some truth to it, as we just heard, in terms of who got the vaccines first, who got the treatments first. Right now, we're seeing the same sort of situation with both Paxlovid and Evusheld, which should be globally distributed according to risk. Rather, they're focused on a couple of countries that have access to them. We haven't even, as we just heard, like we haven't even gotten vaccines out everywhere. And you know, India got hit with Delta before having had, you know, widespread vaccinations. So this is, I think this is the deal reality, is that the privilege and the wealth doesn't get people to live in an island. So we are connected and we have to make all of this thing work. It's the moral thing to do. It's also the smart thing to do. Like, even if it was not the moral thing to do, it would be the smart thing to do, but it's also the moral thing to do. But on the other hand, we're still living in a world where we can witness massive moral failures that go back to sort of if people have followed, I'm sure you know, the access to HIV medication. It's one of the greatest moral failures of 20th century, to this day, not completely resolved, and to this day fuels a lot of mistrust in lots of places around the world, because it's a way in which you've been failed and declared disposable as human beings just for completely over small amounts of money to boost. It's just horrific in all kinds of ways. So I think this is sort of where we are, is that could it go on this way? Probably. Will the wealthy and the more privileged be somewhat isolated? Somewhat, but they're not invulnerable. They are also going to be affected. But they could also let this be and kind of keep using, you know, the wealth and the privilege to suffer less from it. So that, I think that's kind of the challenge, is to make both the case that this is not smart, but also the case that it is in fact morally unacceptable. Like, if we keep, I sometimes hear these sort of narratives that say, if we don't do this, everything will be terrible for us. And I kind of want to say, you know what, they can probably get away with it. They might just hear that and think, we'll manage, which has a grain of truth. So that's sort of the dual challenge I see going ahead. And I want to sort of close with one more thing. The lack of proper HIV treatment and the number of people suffering from chronic immunosuppression and infections because of that has probably contributed both to the death toll and the suffering in places where untreated HIV is still rampant, which is, again, I think it's the greatest moral failure, what happened there. And plus, a lot of sort of scientists think that is a way in which we get these rapid evolution variant events, because you have somebody with, you know, 100-day, 300-day chronic infection. So it does kind of feed into both of these truths, which is that it's immoral to behave this way. And it is also going to puncture those sort of vulnerability islands, the invulnerability islands that we try to build for ourselves using wealth, privilege, access, and all the rest of it. So that's why I really hope, like, we have to go back and say, we got to get a WHO that functions the way it should, with the proper funding, the independence, the high level staff, the kind of the best people working there, because it's true for the CDC, it's true for all the sort of public health, and just learn from wherever that kind of expertise and practice exists. And it's not always the wealthy countries, as we just heard, that expertise and practice of global health is sometimes better in places that had to do more with less, because they had to be better they couldn't just rely on, resources and money to address the crisis.
So thank you, Zeynep. You've just opened a number of areas for us to talk about. We're going to run out of time quickly, but I'm going to, and I want you to know we're going to make time for some questions. So if you want to think about those. But John, obviously, you're coming in as the new PEPFAR coordinator. Congratulations again on your confirmation. Given everything Zeynep just said about the moral failure to address HIV/AIDS, PEPFAR is an $80 billion investment in addressing the HIV/AIDS epidemic on the African continent. We often think of it as one of the few success stories where American universities actually gave away knowledge, where they provided resources and built institutions that now stand on their own on the African continent. However, right, there are so many shortcomings. So would love to know your thoughts, John, on these two questions of you've spent your entire career ultimately addressing false and racist ideas about the African continent as you have straddled, right, between America and the African continent. You've helped build some of the success stories. Do you agree that there's a moral failure in how we've addressed the HIV/AIDS epidemic? How do you think about sort of where we need to go next with this?
No, absolutely. I think let me start with a little bit of history because and very briefly say that the HIV/AIDS around the mid-90s will go down in the history as a very sad moment in our humanity because of the time where ARV drugs were available and the time where it got to a country or a resource-limited setting. And in a continent like Africa, between 1996 and 2002 or 3, about 12 million people died, and I argue needlessly because of that inequality, massive inequality. And we had the drugs. And I remember I was a young public health expert in Côte d'Ivoire, Ivory Coast at that time, working for the US CDC. And we're trying to introduce ARV drugs, starting with a double therapy, which was not optimal, but that was the only thing we had, and progressively there. But let's move forward and celebrate the good news. The good news is that HIV also, despite that dark moment, that also offers an opportunity to celebrate what is possible with humanity when humanity is at best. The creation of PEPFAR in the early 2000s was a turning point in trying to define the trajectory of the HIV pandemic, and I use the word pandemic very deliberately. It is still a pandemic in most parts of Africa. PEPFAR turned the corner. At that time, life expectancy was decreasing sharply in many countries in Africa, you and I know, and because of efforts like PEPFAR, and it reversed the course. That is humanity at best. I think that is where human beings, when they applied their minds and souls to solving a problem that affects the neighbor, we can do great things. The creation of PEPFAR, of a global fund, is also a good example of where we spoke earlier of multilateralism not working well for COVAX, but that is a good example of how multilateralism has worked, where we applied ourselves to the right cause, and the Global Fund was created, and the combination of Global Fund as a multilateral program and PEPFAR as a bilateral program created a scenario where HIV, we can actually hope and aspire that HIV can be defeated. Now, a lot of work has gone into the fight against HIV, as you and I know. I've argued we've bent the curve. We are now at a tail of a pandemic that is very resilient. HIV virus is a very, very resilient virus. We need to look at a couple of things very deliberately. One is, how do we sustain the investments that we've put in collectively from the early 2000 via bilateral programs like PEPFAR and the Global Fund? What do we do to sustain that? Second is, how do we make sure that communities continue to be at the forefront of this and exercise ownership of this pandemic? this pandemic, meaning HIV pandemic, and also leadership of the pandemic, because the pattern has changed significantly. As I said, in the mid-90s and the early 2000s, it was very easy to see HIV all over the continent of Africa. I used to work at the infectious disease clinic at the University Teaching Hospital in Abidjan. You saw AIDS patients all over there. That you don't see that anymore. But so it means that the fight has become even harder to get to that target, which we agreed to set, which we've set for ourselves by the year 2030 to bring HIV/AIDS to an end. That is, it means we have to be resilient. Thirdly, we have to be innovative. We need new solutions at this point. I mean, we have to be innovative in our prevention strategies. We have to be innovative in our treatment strategies and look at new molecules that can be long-acting and new ways that we can empower communities, innovative ways that can actually make us know people that are infected and how, if they are infected, we bring them to fore. Fourthly, we have to make sure that stigmatization is brought to a bare minimum. We have to fight that fight with the understanding that the enemy is HIV. The enemy is not people. Okay, so that we all come together as we did in the early 2000s. That led to the creation of PEPFAR and the Global Fund, and say, look, let's focus on, ask the right question. The right question is, where is the virus? And we go where the virus is and use all the strategies that are just outlined to fight it. I think that is what the task we have ahead of us to get to 2030, which we hope we can bring HIV/AIDS to control. And not forgetting children, because that is a whole a subset of the population that I believe can easily be neglected. And I bet there's a real opportunity there to bring pediatric HIV/AIDS to an end and celebrate that victory.
Thank you, John. We do have time for some questions. Do we have? Okay, well, you think of your questions. I have a lot more. I want to ask both of you. This is, of course, such an important discussion and conversation. There's so many more details we could go into. But in light of where we're at, and this being commencement weekend, I would love to know a little bit more as to where do you draw your, not just your moral compass, but also your intellectual compass. When we, in this pandemic, started out, I think to some extent, the pandemic showcased to everybody in society what cutting edge science is like, which is a whole lot of uncertainty, new phenomena, and we just really don't know much. We try to learn by throwing everything we have at the problem. But within that time, as we have seen, there's lots of different interpretations of, what could be going on and not. Is the virus airborne or not? Should we be wearing masks or not? Very courageous and wonderful piece by Zeynep on looking through the actual evidence. You both have rubbed against sort of public health gospel in this pandemic in important and meaningful ways. Where does that come from? What in your training, what in your experiences has gotten you here? What can you share with our graduates today as to how you look through evidence, how you maintain your moral compass? And I know it's two things in once. Mm-hmm. It's a university, I'm allowed to ask complex questions.
Should I go? I don't know. So this is like a really complicated question, obviously. So the first thing is that, as an academic, I have this incredible privilege, right? I have a job that allows me to do just that. So it's not, sometimes people say, oh, this is brave, that is brave. I'm kind of like, no. I mean, yes, okay, fine. Maybe I get some pushback from colleagues, or if people really get pissed off with me, maybe I get really terrible teaching assignment. I don't really, you see what I'm saying? Like the stakes, when I did first write these pieces arguing that we should be wearing masks, and we should also later arguing that airborne transmission should be taken seriously and all those things. On the one hand, the thing I really did not like was that I was writing against CDC and WHO recommendations at the beginning of a pandemic. And if you told me that's what I would be doing during a pandemic before this, I would have just said, absolutely not. Like I trust in those institutions. I believe in their mission, and like the idea that I would start off by saying they were wrong about something, like just would have sounded crazy to me. And the way it kind of came about is that I tried to get other people to write those pieces. Like I hoped like it would be somebody like an ex-head of CDC who would say, we should be wearing masks, whatever the current one says. Or I thought it would be some, high-level ex-WHO people who would say, you need to stop dragging your foot on this whole airborne transmission thing and look at the epidemiology. I really did try other people would be that. And there I realized being a bit of an outsider was actually an asset, that there were a lot of hesitations because people didn't really want to seem like they were encouraging the quackery or challenging the CDC. I mean, there's a reason medicine is somewhat hierarchical, because you don't want everybody to have their own idea about stuff. That's completely understandable. On the other hand, I was really convinced that the evidence was clear on both of those issues, and that it wasn't just me. Like there's a lot of scientists in other countries, in Japan, in Hong Kong, in South Korea, that I read and talked with. It was more the Western oriented institutions that were saying one thing, and there was a lot of science and there was a lot of epidemiology that just didn't work any other way. So I thought, all right, fine. I'm the outsider who can write this. I'll do this. And worst comes to worst, it'll be the end of my public writing career. And like, yeah, it's a thing, but it's not like rushing into a fire kind of thing. So it's not like, I didn't really feel that sort of brave doing it. I just thought like, maybe it's a pandemic. If you're not going to speak up, when are you going to do it? Right? Like if you have tenure, you have this privilege, you have access to some big platforms. And if you're not going to speak about something that you believe is essential and true and scientific, what then? My fear really has been, it's the same thing the whole time, is that if you're really going to challenge big public health authorities, you better be right, because there's this undermining of confidence issue, and you really don't want people to, and this is where it goes to, when people say, like, it took us 2 years to get the CDC to say, yeah, like N95s are better for high-risk people, right? They just would not advise people on which masks are better, which is very frustrating. So it's in that background, it's hard to argue with an anti-vaxxer saying, I'm doing my own research, when for 2 years I keep telling people, do your own research on masks and mask accordingly, instead of just going with the existing recommendations, which are insufficient. So that's the blind that intellectually that I think about the most, like not as a personal risk, because personally I'm okay, but I would hate to contribute to that problem. So I think like a million times and talk with lots of people and check with many scientists across the world before saying a word that challenges what is the established sort of guidance coming from them, because I think that should be a very high bar. It's not easy, and this is why going forward, we have to fix how this happened, because it is absolutely not acceptable to not be able to really just rely on them and say, listen to what they're saying, because the result is an environment in which you lose trust and credibility on everything, not just the one issue that we ended up challenging in, and makes everything else very hard. So the ideal pandemic experience would have been one in which neither I nor any of the sort of independent, doctors, public health people who ended up having to speak up out of necessity thought they would need to do that. We should have been irrelevant. And if we fix this, we will be irrelevant except as like little voices just amplifying high quality guidance and advice that we get in a timely manner, and not go through this very morally challenging, because, again, if you told me that you'll end up, challenging global health institutions on something like that, I would have said, no way. That would have seemed antithetical to everything I believe in, but yet we found ourselves thinking and doing exactly that. And I hope it never is a case again that we even think about this. And that's the goal.
John, what are your thoughts?
Yeah, so I think I have 3 sets of thoughts. One is especially speaking to the students, that you always have to maintain your the core principles of public health practice, which essentially speaks to the fundamental values that underpin it, which is the trust and credibility of what you do. So that is one set of it. The second is that there's a whole world of difference between public health learned in academic institutions and the practice of that public health in the field. And because, as we said, your strategy, like if you develop a strategy to go to war, is only as good as when you hit the enemy. When you hit the enemy, it changes completely. But what guides you through those storming period are the core values of public health, that which is factual, has to be evidence-based and data-driven. So that leads me to the third and the last reflection, which is that when you approach a new virus or a new pandemic, approach it with humility and approach it with open-minded. That says that you admit that you learn and share the information that you know and enrich that information as new data emerge. I believe that it was totally unnecessary that there was a fierce debate whether COVID was airborne or droplet. I mean, the easiest thing to do was to say that we will learn, as we gather more information, we will improve our knowledge and share that with the community. There's, about the big institutions, is that humility for big institutions to admit that we are learning. It's a new virus and that every pandemic is different. The 1918 pandemic was so different from this pandemic because, just as an example, it affected very young people between the ages of 20 to 40. Okay, this pandemic tends to hit the older people. So these are 2 viruses that are respiratory borne, but they tend to behave very differently and whatever. So it is very easy to try to extrapolate lessons from 1918 to this pandemic. But if you have the humility and the open-mindedness to say that even if you're a big respected organization, you learn and you continue to be very transparent with the information that you have and be humble enough to say that we don't know what we don't know, and when we know it, we'll share it in a timely fashion. I think that will continue to uphold that trust capital, which is so valuable for any public health practice. You lose that trust capital, your public health practice goes down that range. And it takes, as we all say, it may take 50 years to build a public health organization, but it takes just 5 minutes or 5 hours to destroy that credibility. So those are some reflections that I can think of very early on with respect to that complex question.
Thank you so much, John. And now we got a couple of questions, but we're also at time. So maybe we'll take one question from the gentleman over here. We have.
This is probably a question for Stephanie. Last name. Looking at what's happened this week in Uvalde, I'm starting to see gun violence. I'm starting to see gun violence to be an American epidemic at the very least. Do you see gun violence to be a public health epidemic problem?
Well, we happen to have the country's leading gun violence expert right in the front row here. So,
and who actually wrote a piece on how to.
Do you want to give the mic to Megan for a second?
Knowing that we're kind of at time, Megan ran. Nice, yeah. Yes.
Okay.
That's the short answer.
She has a piece on it. Like she has a piece on how to sort of think about it through a public health lens too, if you want to look it up.
It was in the Atlantic a couple days ago. Happy to share it. But the short version is it's been an epidemic in this country for a very long time. worsening since the early 2010s, started to spike even prior to COVID. Over the past couple of years, we obviously saw a decrease in school shootings because schools were largely closed, but those are now rising again. More than 100 people die, more than 200 are injured every day across the United States, and this clusters, right? So young Black and Hispanic men are 20 to 30 times more, huge racial element in gun homicide. There's also a racial element in gun suicide, where older white men are 2 to 3 times more likely to die of gun suicide. We see actually similar rates of gun death in rural and urban areas, but slightly different patterns.
Yeah.
And mass shootings, as horrific and never events as they should be, are only about 1% of the gun deaths in our country in a given year, depending on how you count them. Yeah, but we have the exact same challenges that they just talked about for the last hour around COVID exist for firearms. We have no data, we have no community will, we have and some spreaders of disinformation, and yes.
Disinformation.
Yes, so happy to chat more, but yes, is the quick answer.
Thank you so much,
Sorry
Megan.
to
I'm
take it from you guys.
No, it's
I'm
great
gonna-
you were here.
Yeah, I'm going to close this out and then we can chat more individually. But as Megan has also just said, obviously there's a common current amongst a lot of these issues, and that is what we call the social determinants of health, right? So all these different factors of living conditions and prosperity and so forth, and how they interact with health outcomes. I'm going to close us out with just some words that we've heard today. We want to fail from an ideal and address our moral failures. We want to get off our invulnerability islands. We want to sustain investment and be innovative. We want to remember that the enemy is not the people, it is the pathogen. We have to fix how we keep getting here to these same disparate outcomes. We want to remember the core principles of public health practice, trust and credibility, evidence and data. And when we face new challenges, we have to face them with humility and open-mindedness, because every challenge is different and nobody has all the answers. Thank you so much to Zeynep and John for being with us today and for your fantastic work.